Ladies and gentlemen, thank you for your patience in holding. We now have our speakers in conference. Please be aware that each of your lines is in a listen-only mode. At the conclusion of our speakers' presentations, we will open the floor for questions. Instructions will be given at that time on the procedure to follow if you would like to ask a question. It is now my pleasure to turn this conference over to Chris Hund. You may begin.
Thanks, Chantel, and welcome everybody. Thank you very much for being patient with us. We had tons and tons of people joining, and so everybody was coming through the line at the same time. But welcome to the August monthly TeamSTEPPS webinar. This one is TeamSTEPPS Implementation Strategies for Success. And we're very excited about this, and I think that you're going to really enjoy this one. So thanks for taking the time out this afternoon or morning, depending on where you are in the world, for joining us. As always, I'd like to take a moment to offer thanks to the project sponsors, Jim Battles from the Agency for Healthcare Research and Quality, who's the project officer for this project and who funds it, as well as Heidi King from the Department of Defense. Both Jim and Heidi have, from the start, been the people who have really led the TeamSTEPPS movement and have done an incredible amount of work, not only in working on the content, but also in coordinating its growth around the world. So thanks to both Jim and Heidi. The project team, who you're hearing from right now, is Chris Hund. I'm the project manager for this project. I'm from the Health Research and Educational Trust. AHRQ is a part of the American Hospital Association, and we run the national implementation of TeamSTEPPS for AHRQ. Our partners in this project are Impact International, and they are very instrumental in putting on these webinars as well as a whole variety of tasks that go on in this project. So very much thanks to David Baker and his team. So as always, a little bit of background about what TeamSTEPPS is all about. So what we basically run is the TeamSTEPPS Master Training Program, and this is a 2-day course where individuals come with their teams to become master trainers. And then the expectation is that they go home and train people at their organization in TeamSTEPPS. We are able to support you if you ever have any questions, not only about TeamSTEPPS content, but also about anything to do with getting into a training, questions about our website, questions about our national conference that we do every year. Please call this phone number or write us at this email, and you can find all this contact information on our website, which is the teamsteppsportal.org. Okay, as we're getting ready to start here, just a few rules of engagement for today. So what we would like you to all do is, throughout the course of the presentation, as you have questions, write them in the discussion area box, which is on the left-hand side of your screen. That is the best way to get in touch with us if you have a question right off the bat. Maybe you're having some technical difficulties, or just if you have a question about the content. And what will happen is that I will moderate a Q&A at the end of the presentation with our presenters, and we'll use those questions to moderate the Q&A. After we exhaust all those discussion area questions, we will open up the phone lines for call-in questions at the end, but we just like to make sure that we gather and capture everybody's questions that come in the discussion area first. All right, so now on to the main attraction, today's presenters. We have the Vice President for System Nursing Research at the North Shore Long Island Jewish Health System, Lily Thomas, as well as the Assistant Vice President for Nursing Initiatives at the same organization, Kathy Galla. And what what these two folks bring to the table is they not only, of course, are leaders in their institution, but they're really leaders in the TeamSTEPPS world as well. They both lead the regional training center that we have at North Shore Long Island Jewish Health System, and they've done a full-on implementation of TeamSTEPPS throughout their organization, and so they've got some lessons that no one else has to give you, and so I'm very excited to have them here today. That's just a great thing to have them on board. So I'd like to turn it over to Lily and Kathy right now, and everybody enjoy the presentation.
Thank you, Chris. Hi, everyone. This is Lily Thomas. I also have Kathy Galla with me, as Chris said, and we both bring you greetings from the North Shore LIJ Health System, and it'll be remiss of us if we don't begin by expressing our gratitude for impacting both of us personally and as an organization. So I want to begin by thanking Dr. James Battle from AHRQ, Heidi King from DOD, the whole HRET team, which includes Barbara Edson, Chris Hunt, and Jen Brown. Chris, you just heard. And special thanks to Dr. Baker from Impact, because I met him very early in the journey, and I want to thank him for all the support that he has given us so far, and also Alexis for helping us. And I want to thank the whole TeamSTEPPS community. We have been very, very fortunate to become a regional training center and meet a lot of people in our journey, and their questions each time we meet help us go further and, explore the answers. So with that, our objectives today are, as we share our exemplar and you listen to our experiences, that you'll be able to describe the phases of TeamSTEPPS implementation as well as recognize the barriers, and we'll be able to explain and go through some proactive solutions. You'll be able to describe that as well. With that, I want to go to the next slide. I want to give you a background about our health system in the context of TeamSTEPPS implementation largely. So we are considered the third largest nonprofit secular health system by looking at the number of beds. We have about 16 hospitals, which 5 of them are tertiary and 7 community and 3 specialty hospitals. That means we have 1 pediatrics, 2 behavioral health. We have 3 long-term care centers and home care, hospice, EMS, which is a statewide program, as well as a large physician practice and outpatient network, which is considered the 6th largest in the country. And the reason I'm bringing that up is when we talk about TeamSTEPPS implementation, we have implemented TeamSTEPPS system-wide. Next slide, please. Also, before I begin, I want to say that we have published our experience of implementation in BMJ. It was published online in December 12th, and in the special edition of Quality and Safety in May of 2013, and we can make that reference available. It's already posted on the website, by HRET. So our journey began in July 2007. It was in the wake of an error that, we were having a discussion here, and my chief nurse executive came to me, concerned about the error that had happened at that time, saying that we need to do something different. We have multiple safety initiatives in, place, and I'm sure many of you listening in can identify with that. So I was heading towards the Summer Institute of Evidence-Based Practice, and we always saw cutting-edge strategies there. I was hoping that we will see something different and unique and we could bring back. And I was not disappointed because I saw Heidi King present the TeamSTEPPS program. It was in July 2007. They had presented this it came to the public in November of 2006, so we became early adopters. And I want to say that we implemented TeamSTEPPS in our pilot hospital starting in September before we went to any kind of training. We educated ourselves, and we had contact from Dr. Webster in the DOD so that we could ask our questions. Why I'm saying that is because I am so grateful to AHRQ for putting the curriculum, a standardized curriculum together with the multimedia toolkit which we were able to use to do that implementation. And later on, as soon as master training became available, we were able to avail that and validate ourselves of what we had done and then, create templates for our future implementation. So seeing the success of the pilot program in our community hospital, our senior leadership decided to spread the system-wide. And I want to tell you all that at that time, we did not have a lot of quantitative data, but just seeing the change in the organization, the anecdotal records itself was great for them to decide and make the decision that we are going to go forward as a health system and spread. That means we had to come up and design a plan to spread to our 15 hospitals at that time. At that time, it was 2 long-term care centers, but now we have gone on to more. We have more than 33,000 employees trained, and this number keeps changing as we have new hospitals join us, and even right now the number has gone up. So that is where we stand in terms of, our journey. But again, just to give you a mindset, so we have multiple safety initiatives in place, and again, typically what happens is as we start an initiative, we have excellent results, but then as we shift the focus or the priority shift, then again, you see that, we are not able to sustain results as well. So the vision of our senior leadership was that we now needed to transform our culture to a culture of safety. That meant that the attributes we were looking for was that there'll be zero tolerance for errors, and everyone is empowered to speak up and take appropriate action to promote safety. So that was the mindset in terms of adopting TeamSTEPPS, and I will tell you how it's translated into goals. So going to the next slide, once we had success, so we went and did the implementation of the pilot hospital with the people who were here. I led that, and I had other people with me who were educators and executives, with people with executive experience and project management. And once the decision was made, the health system decided to hire 4 more physicians at the corporate level who could go and oversee. That would not be their only responsibility, but they would be overseeing that. And we have not changed that structure as we have completed implementation as this is going on. The advantage is that there's a central guiding team which is responsible. This team is responsible for designing implementation everywhere. If you see the pictures on the slide, we reflect acute care, we reflect long-term care, our home care, and our EMS. So basically, what the team does is design the implementation, continue to monitor the adoption, and they are functioning as ongoing resource. So every organization knows whom to call if they needed redosing or they needed help. We continue to do the master training, and we are the faculty also for the regional training for national implementation of TeamSTEPPS. So with that, I just want to go to the next slide. I'm sure all of you who are familiar with the curriculum are familiar with this slide. This slide was the slide that we designed our implementation from. So basically, it shows you phase 1 as assessment, phase 2 as planning, training, and implementation, and phase 3 as sustainment. And my lesson is that do not skip a step. Although you see it as phase 1, phase 2, phase 3, it is not exactly linear because right in phase 1, we started thinking about phase 3. That means we needed to put programs in place, understanding that we needed to sustain. So we needed to think about how we were going to achieve that. So that's how we, designed it. So we need to pay attention to every phase, and I'm going to discuss in little more detail in the upcoming slides. So the next slide will show phase 1, which is preparation. So once, we are going to implement TeamSTEPPS in an organization or in a different hospital or a long-term care center, we make it a point to meet with the executive leadership and provide an overview. The leadership will be the whole interdisciplinary team. That means we will have the CEO, the CNO, the CMO, all the C-suite, and people in charge for quality, in charge of finance, in charge of HR, in charge of all the ancillary services. And basically, we sit down and meet, and we give them an overview of TeamSTEPPS and what it would take to implement TeamSTEPPS in that organization. And in return, we also go into a discussion of what is their organizational goals, what is it that they hope to achieve. We knew as a system our goals, but what is it that they wanted to achieve as an organization? And again, so we had to also, at that point, many times they engage in a SWOT analysis, either we are there. So we want to know the readiness of the team. Is the team ready to move on? And then, so based on what they wanted to achieve, we also wanted to see how to measure that achievement, what variable was available, what data was available to measure, and then go on to understanding their table of organization and how they wanted to sequence implementation of the TeamSTEPPS. Then we also wanted to know who would be the point person that we would partner in that organization and would be accountable for implementing TeamSTEPPS along with us. So next slide, please. So again, I talked about the vision of the senior leadership. So the vision was that we needed to build a culture of patient safety utilizing TeamSTEPPS. So TeamSTEPPS offers you the opportunity to make two different kinds of changes. One is the transformational change. That means changing the culture of the organization to a culture of safety. And the second is incremental change. That means you can use TeamSTEPPS competencies to do problem solving or continuous improvement. Now, we decided to do both. But then once you make a decision like that, if that's your goal, then your actions will be built from that. That means, so since we decided we are going to do transformational change, we had to implement all the core competencies of TeamSTEPPS to everybody in the organization. It did not make a difference whether they touched a patient on a daily basis. That means whether they're direct or indirect, our premise being that everybody is impacting the patient and everybody has impact on the team. So we knew that everyone needed to be educated. And then the other part, the incremental change, we wanted to use that. That means selecting specific team competencies, TeamSTEPPS competencies to influence that change, which we always use the PDSA methodology and also looked at data pre-intervention and post-intervention. But those changes were really initiated by the unit or the department at that. So we were both. And they would have that competencies because they're already educated in it from a transformational change aspect. So going to the next slide. So continuing with phase 1 assessment, so, the site assessment, we have all this, you have a site assessment sheet in your curriculum available to you. So since we were doing the, our transformational change was to change the culture, we needed a baseline measurement, and we did that utilizing the Hospital Culture for Patient Safety Survey. This is a reliable and valid tool, which is put, by the AHRQ. We have 3 versions. Many of you may be aware that there is also for long-term care and medical office. We have done all those 3, but in this case, we are talking about the acute care, so I'm talking about the Hospital Cultural Patient Safety Survey. So, and then additionally, say, for example, the pilot hospital, in answer to our question, asking what measure they want to change, the CEO had remarked at that time was, patient experience, and they already have that data ongoing, so we were able to track that. So next slide, please. Okay, so keeping the transformational changes in mind again, so the key question was, what happens in healthcare? We are always having changes. On a daily basis, we have to make changes, whether it is regulatory or because there is new knowledge available or a procedure change, equipment change is constant. And the multiple initiatives in place as well. And I always say that, I know many of you, all of you may be familiar with adoption principles, but we generally find 3 groups of people. One who will be gung-ho, enthusiastic, go with you. But there's always one group which will say, if I put my head down long enough, this too shall pass. And we did not want TeamSTEPPS to be a flavor of the month. So we had to come up with a way, how do we spread this message? And how do we, connect to the changes. What is changing and what is not, and how do we put that in perspective? So we began with the end in mind. Stephen Covey is one of the principals. So going to the next slide, we found a very concrete method. So we have an organizational model called collaborative care model. So it embodies our philosophy, our vision and mission is seen there, our core values are there. On top, we can see our core values of excellence, caring, honoring the human spirit, collaboration, professionalism, leadership, and safety. So the question is, how do you translate these values into daily practice? So in order for that, we use Donna Bedian's classical paradigm of having the structures and processes which would lead to outcomes. So we pointed out TeamSTEPPS was a process used to operationalize our core value of safety. So it is not that we're changing the whole thing. We are connecting to the organizational mission and vision, and we started each and every class with this slide. So where are we? So that the message was that TeamSTEPPS was here to stay. It is going to be foundational basis for everything that we do. And then, you will see on the infrastructure side, you see collaborative care councils, which I'll explain as it comes in the next slide. Okay, so again, from the point of view of sustaining this implementation, so we were thinking about this in phase one before we put things in place. How would we sustain? So we had to have structures in place. So on the left side, when you see an organization level team, which is the executive sponsor, the service level team, and the department or unit level team, is what is mentioned by what's mentioned in the curriculum guide. So we have those teams. Now, at the departmental or unit level, interdisciplinary team is called the change team in the TeamSTEPPS curriculum. We customize that in two ways. Number one, the change team comes into it's organized, and then after implementation, it is usually disbanded. But we saw that having an interdisciplinary team at frontline was one of the best practices for implementing change. So we named the team, the change team, as Collaborative Care Council, which fit in with the collaborative care model of our organization. And also, we said this is going to be a permanent structure. This is not going to be disbanded. This is going to stay, as an organizational infrastructure. And we are very happy with that decision because that's what enables us to sustain it. We have a method to give information. We have a method to extract information from frontline. And frontline is actively participating in creating incremental changes and sustaining team staff. So on the right side, we have said, okay, when the implementation phase of TeamSTEPPS is over, who is going to monitor and who is going to continue? So we wanted to transfer that over to an existing structure in our organization at the system-wide or enterprise level. These are multidisciplinary teams, which is overseeing quality. We call them performance improvement coordinating groups. And these teams at every level is interdisciplinary. It has clinicians and non-clinicians. Or leadership, administrative and leadership is there at every level. Now, something very interesting happened. So even though we foresaw this transition this way, I have to tell you, many organizations have retained their executive sponsor team, and in fact, we recommend that as best practice, and they meet on a regular basis and monitor TeamSTEPPS and continue sustainment, and of course, our collaborative care council continues to stay. Next slide, please. Okay, we are going into phase two, action planning and implementation. So I just finished, different things that we did in phase one, and I'm giving you a very high-level overview, and if you have detailed questions, we can address that later. But going to the next slide in phase two. Okay, so in phase one, when we go into an organization, we ask them, so what is the sequence of your implementation? And this is an example of what we got from our pilot hospital. They had 5 major clinical departments. This we are only showcasing clinical, but we also went to other areas like pharmacy, physical therapy, and everywhere else. But this just showcases the clinical one. So they said, we want to go to med-surg first, critical care then, ED, peri-op, and perinatal. And that's what they came up, the executive leadership came up and asked. But I have to tell you, since it was our very first time we were implementing TeamSTEPPS, we also used one of the med-surg units as a pilot unit before we did pilot implementation in the whole hospital, which really helped us to learn lessons. Okay, going to the next slide, please. Okay, so this is our timeline. So once we had decided we had going system-wide, we had to come up with a very rapid timeline because, again, we were talking about changing the culture of the entire organization. So the senior leadership asked us to give us, a timeline for rapid transformation. On the left side, we have hospitals listed, but you can same way use it for an organization. You can use it as different units or departments on the left side, and on top is the calendar month. We actually plan to transition or complete the adoption of TeamSTEPPS in an organization anywhere from 5 to 9 months, average being 6 months, depending on the size of the hospital. And in all these hospitals, we had to stop one in between because of EMR and then resume. But this really helped us to guide us. Next slide, please. Again, this slide is very, very important to point out a concept. One of the reasons why TeamSTEPPS, has some failures in terms of adoption is because you cannot do random training and random adoption, because many times we say, okay, who wants to get trained? And then, they wait for adoption and nothing happens. But we gave minimum time between training and adoption. That means adoption into practice. So in the classroom sequence, people come and learn what to do, what these competencies are. When we talk about adoption, is now the group comes and decides, the change team or the collaborative care council has to really adopt that into their own scope of practice. So we actually already plan ahead. That means while we were cohorting the training, so we have a sequence given to us. So based on the sequence, we cohort the training also according to the sequence. But we already have dates ahead to say, okay, so when are we going to meet the change team to decide about adoption? So initial transformation in the pilot hospital, we waited until we completed the entire training to start the implementation. But now we have learned by the time we finish about 60%, we are ready to have the dialogue on adoption into practice. Next slide, please. Okay, I'm going to show you 2 templates we developed because we had to do multiple hospitals, and we continue to do that. We kind of created a timeline. This is our guide. This is also a monitoring tool for ourselves. So we divided that with all the actions we needed to do. That means how much prep time we needed in weeks, how much time we needed in assessment. Now we do the patient safety survey as an entire system because we already have baseline and going forward. But at that time, we did not because we had to do individual hospitals, and then we caught up with that. But also there may be other variables that you need to capture before we start as baseline. So we put that timeline saying how much, we need for training, how much time for implementation, and so that we have a guide for ourselves. And next template, please. Okay, this is, again, a very, very important slide for us because as we go into every unit and department, again, in keeping with our goal of transformation of the entire organization, we have to adopt all the competencies that is taught in the class. So, but if you look at them, we cannot really say that, you must do this every single thing every single day because, you see, many of those can be programmed into the daily routine, but others are based on the situation. But still at the learning phase, we needed to keep that in front of everyone. And we began with the easiest one, brief, huddle, and debrief, because at that point we could say, that's what we saw had, enabled the team cohesion and the communication. So, and the least amount of prep was there. But again, I'll just give you an example of one. So even though brief are, we have a template for briefing, we know the definition, what to include and when to do the brief, and then who should be included in the brief, who will be calling the brief, who will monitor. All those decisions have to be made by that particular department. So once it is made that they have to communicate to each other and begin. So those are the decisions they have to make. So we kind of alternated those competencies which needed a lot of prep with the ones which did not need as much prep, because of time, I can answer questions later, but we will fast forward to the next slide. Okay, so when we come to phase 3 sustainment, again, we began with the end in sight. So in phase 1 itself, we had decided, how are we going to be creative in giving the message that this is going to stay. So we began with the organizational model. And then as we spread, we knew that we had to be available. So the team I talked about, the guiding team at the system level, was available for coaching and integration. And the other thing that we required, that we did different, for our organization, we required all the formal leadership to go to the 2-day master training because the philosophy was that they were expected to coach because they are available at frontline, they are there, they are the leadership, they were expected to coach, so they were expected to go to master training. So that is how we prepared for that. And that means, everybody who was rounding, who was monitoring the plan, used TeamSTEPPS, could use the language, could use those open-ended questions to monitor, and we had to do continuous improvement. We wanted to do, as they were doing, continuous improvement from a unit level or a department level to see whether the competencies worked, to get us to the goal or not, or why not. That has to be ongoing. So we were monitoring, how is our process as well as our outcomes as we went along. Whether we were where we wanted to be. Next slide. Thank you. So I just want to share our data of the Culture of Patient Safety Survey for the Pilot Hospital to show you just the trends. So we began implementation, the Pilot Hospital in 2007 was our baseline. We redid the survey in 2009, then in 2010, then in 2011. 2012, we have not surveyed yet because we are with the New York State Partnership with Patients Program, so our survey is coming up in 2013, September. But as you are aware, this survey has about 12 dimensions. And then again, AHRQ puts out a comparative database report every year where we can compare ourselves based on our hospital size or the type of hospital, whether we are a teaching hospital, community hospital, you can do the comparison. We also have our own system benchmarks and to see, what is the difference. But what happened is when we looked from 2007 to 2009, it's less than 2 years. It was about, I think, 16 months. We did not see much of a change in all the dimensions. But if you keep looking at the years, okay, so going from 2009 to 2010, when you look at the change, and 2007 to overall to 2011, we had significant difference in every dimension. Again, so basically what is documented is validated, that, you may expect to see a lot of change, but you may not. That does not mean you abandon, and I'm so thankful to the senior leadership who understood this principle and said, it doesn't matter, that is cultural transformation, it will take time, but if we keep at it, it will take time. So, and that is exactly what we saw. So you have to be relentless in continuing with your processes because you are going to get to the outcomes. Next slide, please. Okay, so in many of the green areas, that we have shaded in green, like organization learning, supervisor management expectations, teamwork within units, it became an area of strength. So when you look at the results, it's about 75% is considered an area of strength. And also what was very, very interesting to see staffing. Staffing changed from the perception of staffing changed from the beginning. It went up 8%, 7.8%. Then again, a huge number afterwards, if you look at it, 17%. But the truth of the matter is the staffing was not changed. No additional staff members were added into the organization. So what that meant to us, when the team members start working effectively, that is what makes the difference in that perception. Because typically when we do improvements, if you ask anyone, what should we do? The number one answer you'll always get is staffing, but it's not just the number, it's how well the team is working together. And that goes back to the TeamSTEPPS whole premise and concept that, when we look at healthcare, we have a lot of experts. But here the challenge has been to take that team of experts and transform them to an expert team. And that's what TeamSTEPPS is accomplishing. so that we can be very effective in our patient safety efforts and in overall efficiency. So what happened to this organization when we looked initially and benchmarked nationally? We were below national level in 9 dimensions, but by the time this survey took place, we were above national average in all 11 dimensions. So we know that the whole concept works and we can transform the culture. Next slide, please. Okay, this is the system level trend. So the system level, we have 2009 to 2011, and the next one is coming is 2013. We are seeing the same patterns, and this time, we know we are holding on to see our next trend. So we have been relentless in continuing to sustain and to go forward, and so we know that we will see the changes as, just like we saw in the pilot, because many of the hospitals we have seen individually when we consider them, the trends have been the same. So with that, I'm going to give over to Kathy Galla to the next slide.
Thank you, Lily. So hello, everybody. So happy to be here with you today. And I also extend my gratitude and acknowledgement to our colleagues from AHRQ and DOD, HRET, and from IMPACT. So this slide is showing you some of our, we're starting to talk about some of our incremental change. And a lot of this work, basically all of this work was driven by the collaborative care councils. So we kept those change teams in place. We have over 330 collaborative care councils system-wide. We have them in patient care units. We have some that are service line-based. We have them in ancillary and support departments. So we have councils in security. We have councils in physical therapy, pharmacy, as Lily said. We even have one council comprised solely of telephone operators. This slide is showing you a reduction of CLABS in patients outside the ICU. This work was driven completely by the collaborative care council in that unit, frontline caregivers. It's interdisciplinary, and they were able to successfully reduce the CLABS rate in that unit by 43%, and the number of line days decreased by 50%. Next slide, please. This is the second example of incremental change that we're sharing with you. The staff was able to decrease their bed turnaround time in this unit and improve their Press-Ganey scores significantly, actually, and their percentile ranking also improved. And then if we could just go to the next slide. Our third example of incremental change was decreasing catheter-associated infections. And the quality rate, as you can see, from the first quarter to the third quarter in the time period where this was measured, significantly went down. Incidence went down from 10.6 and down ultimately to 3.15. And, I just want to share with you, we also have two recent, I would say more anecdotal examples of change and the way that this change has been anchored across our health system. So I'm sure everybody's aware that the New York area recently suffered a visit from Hurricane Sandy last fall, actually. And so, that made a big impact on all of our facilities, in particular our hospital in Manhattan, Lenox Hill Hospital, who was the recipient of many, many patients from other facilities that flooded in Manhattan. So we recently invited some of the emergency department leadership to come and speak at our annual Nursing Leadership Conference, which had a theme organized around leadership through adversity. And, we thought they would come and they would tell their story. That was the intent of inviting them. And we were really so surprised and really delighted when really the entirety of the story that they related to the attendees at this conference was all around how they utilized their TeamSTEPPS skills. And they discussed how they briefed when they knew that they were about to get the patients, and then the patients began to arrive rapid fashion with nothing accompanying them except for possibly an ID band that had their name, no information at all, how they huddled and how they called down teams from other parts of the hospital and cross-monitored each other and situation monitored, how they did handoffs. Their entire presentation about this event was littered really with TeamSTEPPS skills and how that got them through this amazing event. So, that was heartwarming for us. And we were just so gratified to see the effect and the way that the TeamSTEPPS skill set was anchored in this team in a time of crisis. There was no better example. And then the second example that I can share with you that's also anecdotal, over this past summer, we hosted one of our nurse managers from a community hospital emergency department who's completing his master's in nursing administration, and he came to do a 90-day practicum with, 90-hour practicum with our team that goes around the health system and teaches and sustains TeamSTEPPS. So this gentleman got to accompany them to other sites and collaborative care council meetings. He did national training with them. He did internal training with them. And his feedback was wonderful. He expressed that his confidence level, that immediately began using the skills with his own team back at the hospital. His team building skills were elevated. He changed the way that he managed, his perspective on how to grow a team and manage a team. All of that was completely altered by the in-depth exposure to this skill set. And I should really have preceded this story by telling you that he was a recent addition to that facility, and so he had not had the opportunity to be trained in TeamSTEPPS. So this was sort of training by immersion, and it's had a tremendous effect on both him and his department in the way that they react to him. Next slide, please. This slide is really a photograph of some of our staff. So the councils are so engaged in and proud of the work that they do and the outcomes that they've been able to achieve that we needed to give them some outlet. And this actually started, the first showcase took place at our first hospital to roll out. But now all of our hospitals do this, and they allow the staff, or they sponsor the staff really, in all of the departments where the councils are active to showcase one of their projects from the past year. And they develop posters, and staff come down, people from around the health system come and visit while these showcases are held, and they hear about the improvements that they've been able to make. And it's a tremendous venue also for communication and sharing, and it really creates a lot of buy-in, accountability, and is another tool really in our sustainment package. So if we can move to the next slide. We definitely have some lessons learned that we can share with you. So one of them being that initial and ongoing executive leadership support is absolutely essential. We kicked this project off with a letter from our health system CEO to every employee in the health system that TeamSTEPPS was coming and it was going to be how we did business going forward. And that level of support is still visible and has not changed. And that executive level support at the site is also essential. So if you're in a big health system, not just the system leadership, but then the site-based leadership and the department leadership and so on are essential. You need to standardize implementation. We found that to be the best thing across a large organization. And it's very, very important that it be rapid and systematic and structured, and that you continue moving forward, and that everybody understands before you even get started that this is how it's going to be. We train about 60% of the people, and we begin to go live with the use of the skills. We have cohorted units according to the planned sequence of rollout very successfully. So, for example, the operating room, the recovery room, they would be cohorted together and so on. We do use multidisciplinary approach, and we use a lot of our own stories. After we had trained a few groups, we began to use our own stories. That we get really an endless amount of anecdotal feedback now from our own staff. We even made some of our own internal videos because the staff was quick to point out to us, in videos, well, these are just actors. So now we have videos of our own staff using the skills, having briefs and huddles and so on, and they're very effective. Essential to transfer responsibility and accountability to the facility. The facility must own this. They must be ready for it. They must be welcoming it. You will not be successful if that is not the case. And physician involvement is absolutely crucial to success. We found that again and again. Next slide, please. And these are this is really just a snapshot of some of our sustainment strategies. So, we have mentioned some of this. I don't want to be repetitive, but we did begin with the end in mind. We do that with every facility that we bring up, and every training that we do internally, we always connect to our organizational mission and vision. I think in our minds at this point, really, it's not possible to separate the two anymore. And executive leadership support we've spoken about. Actually, we've also built TeamSTEPPS into our orientation programs. It's in our annual mandatory education sessions. Wherever possible, we insert TeamSTEPPS language and skills into our standardized policies and procedures. We celebrate success. That's a lot of what the showcases are about, and sharing best practices. Provides them that annual opportunity to disseminate what they're doing. And the Collaborative Care Council meetings are also a tremendous way. Keeping the change team as a permanent structure allowed us to sustain TeamSTEPPS in another way. So every council has a standardized agenda. Every agenda includes discussion of TeamSTEPPS skills, and are we using them? How are we using them? Should we be doing this, that, or one of the other skills? Next slide, please. So we definitely feel that implementation, across the care continuum, it has been beneficial. We have pulled in everybody who touches our patients. We've done this in our hospitals. It crosses the continuum to our home care. We've trained our case managers. We've trained our CEMS who do transport of patients from one of our hospitals to another hospital and so on. And we've taken it out to our ambulatory network and trained people there. As we keep adding, that network is always growing. Next slide, please. So I mentioned that we've made our own videos. We continue to provide master training, the 2-day training to all of our leaders. As we add new leaders, we offer that training repeatedly to them, physicians and staff. We make tremendous effort to provide training to our physicians. We have been very, very flexible in doing that. We have trained them on weekends, in evenings, in restaurants, in offices. Wherever they are able to stop and listen to the training, that's where we deliver it. We have customized, the length, but we are always true to the concepts and the content. Next slide, please. So some of this is repetitive, and in the interest of time, I think that I would just say that we have also included the skills in our human resource policies where appropriate. We have tried to anchor the skills and the strategies in our daily practice, and we always emphasize to all of our leadership that it is their role to be coaches. So some of them also participate in the training, but all of our leadership are encouraged to be coaches. So I think that is the end, really, of our next slide, please, our formal presentation. And if you have some questions, we're ready to take those now.
Kathy, hi. Thank you and Lily very much for the presentation. And I think we've got two main kind of veins of questions that have come in to you guys. So one of them is a little bit more specifics on training, and the other one focuses in more on defining success, talking a little bit about your measurements that you were discussing with HSTOPS. So let's talk first about the training ones. That seems to logically go first.
Okay.
So folks are interested how much training you provide for each frontline staff member.
So it's usually
what constitutes that?
Okay, so the master training is 2 days, and that's really just for leaders or staff who are going to be trainers. So for the frontline staff, there is the 4-hour training or the 2-hour training within the TeamSTEPPS curriculum. And, we leave that to the leadership at the sites, but I will tell you that the vast majority of our sites have chosen that all frontline staff will get the 4-hour training. I think we have maybe one site that said non-clinical staff could get the 2-hour training. But what we basically do in our hospitals, because we want them, and I believe our leadership's thought process has been that we want them to have the same skill set, to be speaking the same language, and to understand each other regardless of their job function. So we engage them in most of them in the 4-hour fundamentals training. rather than, I mean, we're always open to, we work with sites and physician offices in particular. It's difficult to, shut down the office for a 4-hour training. So as I said, we work with those sites to try and customize and shorten, and I think those trainings have been shorter. But in the hospitals, it's usually 4 hours.
Thanks, Kathy. A question that somebody had goes right into that about those folks that maybe, it's difficult for them to attend a training because, they may be in a medical office and they can't close the office. So what do you pay people overtime to attend those types of trainings outside of the hospital or outside of the normal day? Sorry.
We generally have not done that, no. Some sites may have paid people to come in, but we don't generally pay overtime. And in terms of making them go somewhere, we seldom do that. We usually go to them and even to physicians' offices. So, and for us, our health system is in a relatively tightly contained area. We're spread out across Long Island and the New York metro area, but I know that's not as big as some of the larger health systems out in the Midwest and the west of the country. So we're able to travel to all of our sites, our physicians' offices, and we have done quite a bit of that.
Well, that's good. Thank you.
Sure.
When we're talking about people getting trained and we're considering people going through the 4-hour course, is this something that, I know that you said it's kind of part of orientation, so I guess the question is, do you do it kind of at the same time every month for individuals that are new to staff, or is it on a case-by-case basis and somewhat up to the unit they're joining, or how does that work?
So, this is a different question from when you are actually implementing in a hospital or a new organization, so that's part of it. But those people who are joining the organization afterwards, we have a system-level orientation and a site-based orientation. It is usually covered by the sites because they have trainers at the sites, and they will do for the entire staff who has joined the entire organization. So it is not based on the unit level, but it's based at the organization level. Because on their site orientation days, some of them do it on the first site orientation day, some of them do it on the second site orientation day. So for all the disciplines, it's one training by the organization.
Okay. So it's one. So there's no specificity for different disciplines. Everybody receives the same training.
Yes, because that's what the whole intention is, that because they are a team which is working together. We also have gone to the same interprofessional training in multiple other areas as well.
All right, sounds good. I know that we have, the time is running down, so I want to switch over to the other vein of questions that we got a lot in on, which was a lot around the benchmarks that you're using with the HSOFs. And so some of the questions are a little bit more specific. There was an individual interested in how long you've been able to sustain some of the improvements that you listed on your slides, that you were listing on your slides in the presentation.
Okay, so how long? So the longest history we have is for Pilot Hospital, where the baseline was done in 2007. We resurveyed in 9, 10, 11. And after 11, I said we have not surveyed because we had to join the same sequence as the New York State. So that survey is coming up in 2013, September. So the sustainment, when we saw the numbers go from 2007 to 2011, up to that, we have sustained all the numbers and everything continued to increase. And interestingly enough, we saw one dimension, not significant decrease, but numbers, remained the same, was teamwork within the unit. That was with 2010 and 2011. But we have still sustained significant improvement in all dimensions for the 4 years. Now, 2013, that's going to be a mystery. We're going to find out.
Well, we'll have to have you back to let us know.
Yeah. So we are waiting too. We are waiting to see now what happened, how much. But the other thing we do meantime is for every improvement that we do, we use TeamSTEPPS as an organizational process because it comes alive again. For example, we are preventing falls, so it's not just a clinical challenge. So we say what TeamSTEPPS competencies we are using to do fall prevention. So for pressure ulcers, we have done that. So that's how we bring it back. So hopefully everything sustained, we'll find out.
Yeah. So what you're saying is that you're not basing your success just on the data of the safety survey, but you're also basing the success based on those kinds of safety events that you're cutting back on, like falls and the like.
Absolutely. And also on, the incremental changes that I mentioned to you, those things we continue to track ongoing. Are we continuing to maintain or continuing to improve? And when, if we see anything that ever pops up in the other direction, we're immediately back in there saying, have you, do you discuss this in your brief? Do you debrief? How are you addressing this using the skill set? So again, this not being research, we cannot always, the question comes up regarding, attributing cause and effect. Right.
But recently we had to write, we were submitting an application regarding TeamSTEPPS implementation, and we went back and looked at results. And I looked at it from, so what happened to patient satisfaction system-wide the 5 years before and the 5 years TeamSTEPPS was implemented, so that being the constant of the system. And I found changes like while there was improvement and dips, this was steady improvement. We calculated, say, for example, 2011, just cost avoidance, preventing some of those events. If a team is working well together, we have put TeamSTEPPS in improvement. For 1 year, certain things, we calculated $21 million as cost avoidance. So we were looking at it, from that aspect as well. If a team is working well together, we should see impact in finance and quality.
Right.
We were looking at excess days. That has come down tremendously. So even though we cannot say cause and effect, these are the correlations that are running.
Right. Oh, thank you. We've had some questions coming in back to the training, so I do want to jump back there to try to get them answered. A lot of questions surrounding physicians attending. I know that physicians do get trained, but are they trained independently of the other staff, or are they a part of the 4-hour training that everybody else goes through?
Okay, so we do physician training at all levels. First of all, if they are leadership, and we have put them through master training. Many of them are on faculty with us. They train. They also teach in the master training. So it depends on what level position they have in the organization. So they go to master training. They also come. We have done fundamentals with them. The best method, we say, okay, can you come with the team? But we cannot hold on to one method with physicians because we have hospitalists. We have also community physicians. We have voluntary physicians. So we have taken all kinds of approaches. That being said, sometimes we have done grand rounds, split the 4 competencies into 4 different days of grand rounds.
Yes.
We have met with residents, before and done them separately. We had done for community physicians evening hours. Also, food is a must, so we usually meet in the restaurant somewhere, and the chief medical officer is there. But one of the things we have always held is physicians must be involved in also physician training so that it's, as well as us. So that we have not done one method. We have done multiple methods and continue to do so. But I want to say one thing. Even if they're trained, because we cannot bring them in the group or something if their schedule doesn't allow them, but still they have to come into collaborative care council or to the change team to implement the change.
That's right.
And that's monitored.
And they continue to participate in those councils.
So definitely you don't have an issue with gaining that buy-in. It's kind of just part of your culture that they are bought in already.
Yes. Yes. Well, though, we've had our challenges. It's we just have to keep at it and find the way that works with each particular group of physicians to engage them.
We have transformed a lot of people. It takes a lot of backbone and guts. It's not personal, but one of the physicians said to me, he was a patient safety officer, he said to me, Lily, we were doing an overview. He said, you know what you're doing? You're changing people's belief system. So I came back and said to Kathy, when we look back in history, what happened to those people who changed belief system? They're not here to tell the story. We are still here and doing well. So I don't want to make it sound that easy, but we had challenging questions. But then again, we found, once they got over that, many people became very, very passionate. They're on the road with us. But we have leadership buy-in. So senior leadership has endorsed us. And again, our premise is, or the leadership vision is, this is a competency we expect you to have. And that is vital for our organization. And, some people have been very strong, some CEOs, to say that if you don't have a competency, that means this may not be an organization for you. Many times we don't have to go to extremes like that, but, we have had different levels of difficulty, but overall, I would say they are with us, and which is great. We have a lot of physician partners with us and leadership.
When you look back at the start of your journey and you went down to Carillion for the original training, I believe, how many people did you start off with as your first cadre of master trainers?
Okay, so we had done completed training. We had also done master training for the leadership of the first hospital, which is about a 200-bedded. We had already trained the leaders when we went. So when I went to Carillion, basically we were 3 people at the system level. We had a physician at one of our hospitals in Staten Island and 1 staff nurse. That's all that we're trained. But what we have done is, once we came back, we have continued to keep the master training model very pure. That means master training is only done at the system level and the core faculty remains the same. We'll have different disciplines come in and teach, but the core faculty is same, and master training is only provided by one group, whereas the trainers can go back and train in their institution, and that is how we have kept the model pure. So we were only 3 people, and none of them are here except me.
Yeah,
it's part of the training.
And now for the whole health system, we're only 6 people.
Right.
Wow.
Who do that training, but we have a number of people who are trained in master,
Yeah, so, we have master trainers all over the health system. So when we do a master trainer, we'll invite different people in to teach a module with us.
So stepping back for a second, if you guys still have a couple minutes, when we were talking about individuals attending training and how do you get time for them out of the office, what would you do, what is done for the individuals that are actually working in a hospital, not in a physician office? How do you afford to send these individuals to training, just from one of the units to get them out for 2 hours or 4 hours to go to a training? How is that built in?
So that scheduling has been done very, very creatively. We ran multiple sessions, in a day we run, say, 2 sessions, and we have run through weekend classes as well. So basically the unit, many of them have a way of staffing that on one day they staff more for other continuing education sessions as well as meetings. So the unit is able to be creative. And again, what we do, when we know how we are going to cohort the groups or when we know the sequence, say, for example, it's med-surg unit. So we have 3 East and 3 West, and if we know the sequence, we are able to take people from there and cohort them for the training. We like to keep the same teams come for class because, they're the ones who are working together. So that facilitating the entire process begins in the classroom. It's so strictly only not didactic. So that's how we manage, and we actually are still having that model, and they're able to release people that way, so maybe mixing morning, evening. So we've been very creative in doing that, and we have done that without really paying overtime and managing the staffing like that, So.
Oh, thank you. So there's a question here. I think it's a very good question coming thinking about how you get the training. How do you feel that the 4-hour or the 2-hour like essentials course is enough to train people, because oftentimes people kind of consider that you may need more, and they think about, well, somebody attends a master training course for 2 days, and the first day is all about the skills, basically. How do you shrink that down? How do you think the 4-hour course in the TeamSTEPPS materials is appropriate to teach frontline staff?
So this is the clinicians, but again, see, the 4-hour is, for us at least, it's the first exposure or introduction to skills, right? So they come and learn, and then we have multiple examples to teach them. But then again, remember the time that we are coming back into adoption, and that's where I showed that template, that how we are going to initiate that skills and practice. So the second practice run comes from, to embed those competencies that they're designing. So they learn what it is, but we can re-educate them at that point, and we also redose, based on the study we did, we also redose, as needed, and if we find a need while we monitor. So again, when they're implementing, it's the second shot, saying that, so how are we going to adopt this in practice? Say, for example, if it's brief, they have to come up with the answers, and then we are watching them to see that, how it's not evolving in a different way and it's being done appropriately. So at the monitoring, we have different times that we can educate them. And remember, there are enough prepared people as master training for coaching, because all the leadership, we have sent them to master training. So there are people available on site, available with them.
Thank you. I know that we're way past time, so I kind of want to close things out and thank you guys very, very much for coming on. There was somebody who asked a question about, has TeamSTEPPS ever worked starting off just at one unit and just in one unit level? And, I want to stress that that's definitely, that what's going on with North Shore LIJ is, after years of working on this and years of experience with this, and certainly there are many hospitals out there who send teams to a master training course, and we stress for them, solve one problem first. Work in your one particular unit first. And then over time, as you sustain that and you're able to spread it, then, you can grow to doing what is going on at LIJ or at North Shore LIJ. But I think you, Lily and Kathy, would agree that it's entirely okay to come in and say, let's tackle the OB first, or let's tackle one problem in the OB first.
Absolutely, and that's the best way to connect with them. And many people start off like that, to solve a problem, to do that, and they see the success, and then success brings more success. And it all depends on what do you want to achieve finally, and that's why we spend the time saying, for us it was much bigger because we wanted to do a transformational change. But it works very well to do improvements, and that's what we are finding out, system-wide, organization-wide, or unit-wide.
You make a good point, Chris. I think the incremental change can be the hook and start them on the journey to the transformational change.
So for everyone out there interested, I know there have been some questions about how it is that you can get trained that have come through in the discussion area. Head on over to the TeamSTEPPSportal.org. You'll see that right now all of our courses through September are filled up, but there will be more courses next year, a lot more courses and a lot more opportunities for you to be able to take some courses. So keep an eye on that website. Feel free to sign up for a waiting list for one of the remaining trainings this year. You never know, it might work out. And also the great thing about being on our waiting list is that individuals on the waiting list will get first word of when the new trainings are opened up. So with that, I'd like to thank you both, Lily and Kathy, for the great presentation. I appreciate you staying on after time, and everybody out there, thank you very, very much for coming and spending your time with us today.
It's our pleasure, Chris. Thank you, everyone.
Thank you very much for the opportunity to share. Thank you.
Thank you very much. Ladies and gentlemen, this conference has now concluded. You may disconnect your phone lines and have a great rest of the week. Thank you.